Hi, everyone, and welcome to the Psychosocial Losses of Disabled and Midlife Adults. So, today we're going to be talking about midlife adults ages 40 to 65, approximately, with a specific loss they've experienced of psychological and social losses as a result of the onset of disability and the formation of a disabled identity in midlife. Some general cultural considerations to keep in mind are that disabled midlife adults are often low income and reliant on social service programs for healthcare and support. That's generally speaking. So, moving on, some key concepts that we'll be talking about today include disabled disability and disableism, able bodied and ableism, interpersonal discrimination, institutional discrimination, internalized ableism, disability melancholia, politics of care and confinement, and Worden's task based model of grief. So, to review a bit about the loss event, again, we're talking about the psychosocial losses of midlife adults as a result of the onset of disability and the formation of a disabled identity. An estimated 90 million American adults and 1 billion persons worldwide currently report difficulty with seeing, hearing, mobility, communication, cognition, or self care, or a combination of them. Rates of impairment among young and midlife adults in the US, especially those in lower socioeconomic statuses, have risen dramatically in recent years, alongside population aging, with a correspondence to the increase in physical limitation. Some common occurrences as a result of the loss include interpersonal discrimination, such as microaggressions, being treated like a second class citizen, underestimation of intelligence, skills, and talents, excessive criticism of work performance, bullying, decreases in social networks, some examples of that. Some institutional discrimination as well, including barriers to support, medication, procedures, treatments, and educational barriers. And generally, also, there is a psychological toll that we'll be diving a bit more into, as well as the potential loss of physical ability. So, in middle adulthood, we're talking about approximately age 40 to 65, though the exact age boundaries are fluid and can be based on individual health, well being, functioning, race, gender, sexual orientation, gender identity, and social class. So, various social determinants of health. The beginning and later phases of middle adulthood involve markedly different age related changes, which can be considered an unstable time to experience. The research on midlife is largely based in Western societies and on white samples, so that's very important to consider in some of the research that's available and what we'll be talking about here. The introduction to middle adulthood involves completing tasks such as balancing growth and decline, linking earlier and later life stages like integrating youth and old age, reassessing one's accomplishments for inner satisfaction, and determining future directions. They're also going to be recognizing one's mortality, adjusting to age related changes such as declines in energy, vision, or hearing. They'll be redefining parenting roles with adult children and possibly reaching the peak of one's career. Coping with disruptions of partner relationships are also possible, as well as taking responsibility simultaneously for children, parents, and community well being. Some developmental characterizations of this age group include biological aging processes, such as hormone changes and subjective perceptions of aging. An increase in being socially active is often found, feeling a sense of efficacy and making a difference to be important. Finding balance between developmental gains like self esteem and emotional maturity, as well as losses with things like reduced energy, changes in physical appearance, and greater risk of illness. There's also finding balance in one's life, leading to the exploration of previously neglected aspects through changes in career, location, relationships, volunteering, And for those with adequate resources, middle age can be a time of creative growth, especially with financially independent children. Also, we see in this age group potentially an abandoning of earlier dreams. So, moving on, this age group overall um, has a focus on moving away from previous definitions and characterizations of one's roles within relationships and a moving towards an acceptance of one's biological aging and mentorship. Resolving the conflict is the concern for future generations through leadership, mentoring, and creativity. So they're really focusing on the future generations is what is expected to be thought. However, current economic conditions can often limit choices for many midlife adults compared to previous generations. This can also be a time marked by significant losses, including the death of parents, a partner, sibling, or an adolescent or young adult child. There can be divorce, considerations of caregiving for elders or adult children who might have chronic mental illnesses or disabilities who need a level of support that they, as caregivers, might be able to offer. But, including that, there's the loss of a level of independence potentially. Developing an awareness of one's mortality and creating a sense of urgency about accomplishments might lead to a more selective relationship allocation and resource allocation. Additional losses could be biological aging causes like reduced energy or changes in physical appearance or a greater risk of illness. These losses can be complicated, though, by developmental tasks that are typical of this stage of life. Most midlife adults, though, adapt resiliency by drawing on previously established capacities and coping mechanisms. So, moving into some developmental impacts, disability status significantly affects negative and positive affect. Being treated disrespectfully is specifically one subtype of discrimination, but is one that's particularly consequential and impactful for the well being of disabled midlife adults. And that's because of the breadth and pervasiveness and feelings of demoralization that it might bring on. This disrespect will convey claims about one's competence and undermines one's dignity. And the additional consequences, negative consequences on psychological health can include a reduced confidence overall, a reduced self esteem, an internalization of stigma, which can be really impactful. An internalization of the infantilization that they experience is also something that could be really impactful. The concept of disability melancholia is where socially imposed ideals and denigration can block disabled individuals from processing grief related to their social suffering. This melancholia feeling keeps people in a suspended emotional state where grief might feel that it is not allowed, and it might be internalized through self blame, which ultimately will prevent the formation of secure identities and relationships, especially with one's changing body. Oftentimes, there's a treatment of disdain or disrespect as these disabled individuals are quote unquote violating the cultural norms of able bodiedness and standing out in that capacity. Some perceived interpersonal discrimination is linked to poor psychological outcomes for disabled midlife adults generally. And then midlife adults experiencing impairment as a result of disability might avoid or delay seeking services such as home repairs, bank loans. They might not reach out to family, neighbors for personal care. They might not reach out to the support systems as ways to protect themselves from mistreatment, because opening those doors for connection also open doors for potential mistreatment. There's also a diminished size and diversity of one's social networks that is seen in this population experiencing disability, which can result in a reduced access to engagement with healthcare, social services, and caretaking support. Also, reducing focus on one's growth, rather an emphasis on one's decline. So we're seeing a move away from growth and a move towards the conceptualizing of decline more. We're seeing speeding up of the process of recognizing and grappling and accepting one's mortality and considering what it looks like to have a potentially reduced lifespan that one expected to be longer. Uh, there is a longing for earlier stages of life rather than maybe linking them with the later stages. There's a quicker progression of once viewed as, quote, age related changes, such as declines in energy, vision, hearing, mobility, cognitive understanding, leading to a potential need to transition parenting roles with adult children into that of the children being caregivers, or maybe a need for non familial caregiving is present. There's also a potential need for a transition of partner relationship roles into that of a caregiver and care receiver relationship dynamic. There's a grappling also with the possibility that the end of one's career is present rather than hitting a peak followed by a continuation of career, which is often expected within this age group. Moving into some biopsychosocial considerations, the relationship between disablement and psychological well being can differ by social locations. As disability is already a social location, having those additionally underrepresented minority population experiences create compounding issues. Disparities are associated with systemic issues related to multiple forms of oppression. And that's where we get ideas about intersectionality coming in. Many people with disabilities remain in poverty purposely so that they can obtain health coverages for services that might not be covered by private insurance, such as personal assistance services. There's also barriers to health coverage overall, including a lack of affordability and the presence of pre-existing conditions, creating a exclusion of healthcare. BIPOC adults experience an increased instance of medicalized racism as disabled adults. Specifically, Native populations and Black adults have a higher prevalence of limitations in physical functioning, which speaks to a level of societal and medical racism. And thus, they'll have more opportunities for instances of discrimination in these medical and care environments. Additionally, Black and Latino and Latina adults with intellectual and developmental disabilities have reported to be feeling fair or poorer physical health and mental health when compared to their white peers who have disabilities that may not be as worse outcomes as those who are BIPOC. Adults with mobility limitations who are members of racial or ethnic minority groups are more likely to report that their health is worse a year than it was a year ago and are more likely to experience depression, hypertension, vision impairment, etc., than white people with mobility impairments. Also considering that multi-disabled individuals often experience worse health outcomes overall. As we mentioned, that disabled individuals with pre-existing conditions can experience barriers to health coverage. We also see higher rates of mental and psychiatric disabilities and intellectual and developmental disabilities among LGBTQIA plus respondents, as well as greater prevalence of multiple disabilities for that population. LGBTQIA people with disabilities are also more likely to report a diminished health related to the quality of life, including poor physical and mental health than compared to their non LGBTQIA peers with disabilities. We're also thinking that disabilities and disabled individuals are more likely to have an experience of intimate partner and interpersonal violence. So we're seeing higher rates of that in the population as well. We're also really needing to address marriage inequality that is present in the population. It's often not known that disabled people cannot get married without their social service programs, such as Medicaid and Social Security, being terminated. So there is and consideration of the lack of that equality there. So, the grief theory framework we're going to be focusing on is Worden's task based model, which is specifically recommended for middle aged adults who might be facing multiple losses. The onset of disability is accompanied by multiple losses across various realms: psychological, social, physical, etc. This theory highlights how disabled adults and their grief processes are not linear and often disrupted by systemic barriers and stigma. The model also proposes that bereaved individuals need to accomplish a certain task to facilitate healing, such as accepting the reality of the loss, that can be seen in a challenge of recognizing and naming the socially engendered losses, such as inclusion or exclusion, I'm sorry, marginalization, and diminished autonomy. They need to be recognized not as personal failures, but as systemic injustices. Um, a task, as well as working through the pain of grief and accompanying feelings and emotions that come up. Grief is often complicated or suppressed, where many disabled individuals express that they, quote, don't have time for an emotional life, which reflects that the emotional constraint and melancholic suspension that we talked about earlier inhibits the option and ability to grieve. Adjusting to an environment after the loss involves navigating daily life in inaccessible environments and forming new roles with dependent care structures, which often uh, don't have adequate support or recognition of the needs of the disabled adults. Also, there's the finding meaning in the loss that is really important in this model, and finding an enduring connection with the deceased, which in this case is one's former able-bodied identity and experience, and being able to still have a connection while moving forward. There also might be an obstruction of societal narratives that demand an assimilation into non-disabled norms, which will limit opportunities for meaning making or community building around shared disabled identity. And so this model really seeks to address that meaning making and community building opportunity. Additionally, this model seeks to examine and adjust coping styles and methods. So, for a comprehensive assessment and intervention strategy for disabled midlife adults, we need to talk about addressing the complex interplay of systemic oppression, psychological loss, and coping styles. We need to focus on normalizing and validating psychological and psychosocial losses, incorporating psychoeducation to distinguish between internalized ableism and structural disableism as resources of grief. We need to emphasize that the emotional response to marginalization is not weakness, but a valid human experience. We also need to acknowledge the deep emotional and psychological toll that disableism, alongside material injustices, can provide. We also need to consider what it's like to facilitate problem focused and emotional focused adaptive coping, such as reappraisal and self advocacy. The goal here is to reduce a reliance on maladaptive coping strategies like avoidance or helplessness. We're going to be introducing skills such as mindfulness and emotional regulation to help manage the overwhelming effect and rebuild resistance and resilience. Um, in the rebuilding of meaning and connection, using peer led disability support places and spaces to foster collective grieving and mutual validation can be really important. Also, which is critical for politicizing effective loss into action. So we see a lot of activism spaces coming out of these peer-led disability support services and groups. Also important to consider promoting engagement in community-based or virtual activism in general, to find a way to endure connection while shaping new futures. We need to also focus on integrating developmental and cultural contexts, such as addressing unique midlife grief experiences like the loss of future dreams, changing family roles, and a heightened awareness of mortality, while tailoring interventions based on race, gender, class, and ability to acknowledge the intersectional nature of grief and the resilience of midlife overall. So, in this assessment, the strategy looks like four various tasks. The first task is accepting the reality of the loss, exploring what loss the individual recognizes, such as independence, employment, identity, and care supports. And using a psychosocial loss questionnaire and narrative therapy would be helpful to evaluate the perceived extent of both tangible and intangible losses. The goal for this step is to determine whether the clients have acknowledged the impact of the societal and structural disableism that they experience beyond their medical diagnosis and what that might mean for them. The second task is working through the pain of grief. Here, we're going to examine how clients express or suppress their emotional pain using narrative therapy to evaluate signs of the melancholic suspension that we discussed, where individuals, again, will feel emotionally frozen due to an internalized depression. The goal for this step is to identify emotional blocks such as shame, guilt, and helplessness that might prevent processing grief. Task three is adjusting to the new environment, evaluating how clients are adapting or not to changes in their social roles, the environment, and daily function. We're going to be doing check ins, especially with changes in caregiving, work, and relationships in this step, with the goal ultimately to assess the readiness and the resources for role redefinition and daily life adaptation. The fourth and final task is finding a way to remember while moving forward, examining how clients make meaning from their losses and sustain their identity through this experience. We're going to assess involvement in disability advocacy or peer communities as a sign of transformed grief into empowerment. The goal for this step is to identify how connection to collective identity and activism can support emotional healing and post traumatic growth. The evaluation of this theory, the Worden's task-based model of grief, um, includes the structured, adaptable nature of the model. We see that it supports ethical service delivery and centers clients' evolving needs and their agency. The model's flexibility allows for an integration with culturally informed practices and alternative grieving traditions, which is consistent with standard four of the social workers' standards of care. The model originally was developed in Western contexts, though, so it requires modification to honor and address diverse expressions of grief and healing, which invites cultural humility rather than cultural imposition. um, Watermeyer's theory of disability, melancholia, and emotional life that we talked about centers on the emotional experience of marginalized individuals, which directly support the NASW's emphasis on recognizing the inherent dignity and worth of people and advocating for vulnerable groups. This call to recognize the psychological consequences of systemic ableism aligns with standards one and two of cultural competence, which requires social workers to be aware of their social injustices and their psychological effects and to challenge these dominant cultural narratives. While the theory is rooted in South African context, it offers a culturally transferable framework for acknowledging grief across intersecting identities, which reinforces the social work commitment to intersectionality. Then Loan and Edwards' politics of care and confinement, empowerment and advocacy are something we also had talked about. Their framing of collective care as resistance is highly compatible with Standard 6 of the NASW, calling for empowerment and structural advocacy on behalf of marginalized populations. The use of digital mutual aid networks embodies the social work commitment to strengthening human connections and community resilience as well. Um, The article that I specifically referenced for this, the Luann and Edwards article, specifically critiques neoliberal care frameworks, which resonates with social work's anti oppressive stance and the call to, again, dismantle systems that fail multicultural populations. However, cultural specificity might require an adaptation for this theory, especially outside of Western European contexts. And then the Geddick et al.'s article that I also am referencing here talks about the coping style mediation in psychosocial loss. Here, the emphasis on supporting clients to use problem focused coping aligns with ethical standards of competence and client empowerment. It also recognizes that psychosocial loss is not solely determined by physical impairment, which fits well with the person and environment framework of social work. And this specific study was conducted in Turkey. So the study implicitly supports cultural competent practices, which is compliant with Standard 3, which suggests the need for a nuanced, content based understanding of coping, resilience, and grief across cultures. And lastly, some implications for social work practice. Um, when applying the task based model, it offers a unique, non conventional perspective on losses that disabled adults face, such as the loss of autonomy, social status, bodily functions, and career opportunities. So, incorporating Watermeyer's concept of disability melancholia helps social workers understand that disabled clients might not be stuck in grief due to pathology, but due to systemic oppression and a lack of social permission to grieve. For disabled individuals, midlife can accelerate typical aging experiences like the loss of energy, caregiving role changes, diminished independence, and compound them with disability related discrimination and systemic barriers. These ideas introduce the concept of grief in the population. It isn't always tied to a single event, but rather a continuous negotiation with marginalization, isolation, and shifting identity. By addressing how race, class, gender, and sexual orientation impact the experience of disability and grief, these ideas overall can offer a person an environment and intersectional approach, which is core to the social work values. It's also important to name specific systemic challenges like medical racism, marriage inequality, Medicaid limitations that complicate the grieving process and the daily living, especially for BIPOC and LGBTQIA plus disabled adults, and can help push social workers to look beyond individual pathology, recognizing the structural roots of psychosocial losses. Using an adapted intervention strategies like validating psychosocial losses, supporting emotion regulation, creating space for community care, and promoting activism as healing provides tangible tools rooted in social justice rather than just theoretic tools. These ideas offer a culturally responsive and developmentally appropriate approach that also aligns with centering client dignity and lived experience. The ideas also encourage social workers to validate grief related to systemic ableism and not just medical conditions, understanding the impressed nature or the suppressed nature of emotional expression in disabled communities, using trauma informed and strength based approaches to support clients through identity transformation and social navigation, considering how advocacy and community engagement can be sources of meaning and healing. These ideas also just call attention to needed systemic changes, like increasing access to social services without penalizing for marriage or income growth. And the role of social workers as advocates is kind of the main implication of this presentation. So here are the resources that I have used today. Feel free to take a stop and screenshot. But overall, I just want to thank you all for watching. just reminding you that disabled adults, especially disabled midlife adults, are in need of support that might look different than non disabled adults. Thanks.